and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Sodium glucose 2 cotransporter 2 inhibitors block glucose resorption in the kidney and were designed to treat type 2 diabetes. However, they've also been shown to have significant cardiovascular and renal benefits. Individuals with lupus were excluded from the original clinical trials of sodium glucose cotransporter 2 inhibitors. But as clinicians, we might reasonably question whether the benefits of these drugs extend to people with type 2 diabetes who are also living with autoimmune diseases. The manuscript we will discuss today is Efficacy and Safety of Sodium Glucose Cotransporter 2 Inhibitors for the Primary Prevention of Cardiovascular, Renal Events, and Safety Outcomes in Patients with Systemic Lupus Erythematosus and Comorbid Type 2 Diabetes, a population-based target trial emulation. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. I am so happy that Karen Costenbader, the senior author on this manuscript, could join us on the podcast today. She is the first person to be on ACR Journals on Air twice, and someone whom we all aspire to emulate. Dr. Costenbader is Professor of Medicine and the Michael E. Weinblatt Distinguished Chair in Clinical Rheumatology at Harvard Medical School, as well as Director of the Brigham and Women's Lupus Program. She's led numerous prominent epidemiologic studies investigating autoimmune diseases and their associated comorbidities, with a particular focus on lupus. Welcome back, Karen.
Well, thanks so much for the invitation, Vicky. It's very nice to be here, to be back. I don't remember when last time I was on ACR Journals on Air podcast with you, but it's so very nice that people are interested in our work and this work, and I'm very happy to be here.
So I wanted to start our conversation by having you fill us in on why this study was needed. Can you tell us more about the background?
Well, yeah, you did a really nice job of framing it, and that's a good question. So the SGLT2 inhibitors, including all the gliflozins, dapagliflozin, canagliflozin, empagliflozin, they're kind of exciting, newish medications that came onto the scene about, early 2010s, 2015, and they were originally for type 2 diabetes as oral hypoglycemics. And they work by blocking glucose reabsorption in the proximal tubule of the nephron, and that leads to a lot of blood sugar going out in the urine, so they lower blood sugar. But then quickly thereafter, they were found to have all kinds of great kind of side effect benefits. They were found to protect against some cardiovascular disease, and in some studies, major adverse cardiovascular events such as myocardial infarction in patients with diabetes. But even more so, they reduced the risk of heart failure, both heart failure with preserved and reduced ejection fraction quite a bit. First in diabetics, and then those with cardiovascular disease, and then even in the general public. And then there were other trials that showed that in people with diabetes, first, there was really a profound reduction in the progression of their diabetic nephropathy with decreased proteinuria and slower decline of renal function, and fewer patients going on to chronic kidney disease and end-stage renal disease. And then they were tested in other renal disease states, not just diabetes, but also hypertension and ischemic nephropathy and others. And they slowed the progression of renal insufficiency from all types and proteinuria as well. And then there was just one study of an autoimmune disease, IgA nephropathy, which also had positive renal effects. And then, as you mentioned, patients with lupus have really greatly increased risks of cardiovascular disease, and a lot of them get lupus nephritis. Probably half of patients get renal disease. But these patients have been excluded from these big trials in the past for a variety of reasons, because there's a lot going on with patients who have autoimmune disease and are on immunosuppressants. And so it seemed like a really good population in which to test the potential other benefits of these new medications in addition to standard of care for lupus.
So, dare I ask, why were people with lupus and other autoimmune diseases excluded from the original clinical trials for these agents?
Yeah, at first I thought it was because of the potential increased risk of infection, because there is an increased risk of infection that's been noted with these medications, especially genitourinary infections, which we can talk about later. But I actually think it was also because most of the trials are relatively short term, and there's just a lot going on with people who have, especially lupus nephritis, they're very heterogeneous, or other autoimmune diseases. They're treated with many different medications, immunosuppressant medications. There's not a standard, and there's just a lot of fluctuation in disease activity, and there may be a fluctuation in the degree of proteinuria and eGFR. And it would be probably difficult to assess the effects of an SGLT2 medication in that setting. So there are challenges for studying these populations as well. And I think that was probably part of the motivation in the big trials to keep it more, cleaner with people who have renal disease because of diabetes, ischemia, hypertension, etc. Then they would all be more similar. But it's a shame because then we don't know if these medications would work or if there would be any other risks in our populations.
So you evaluated two classes of drugs in this study, the sodium glucose cotransporter 2 or SGLT2 inhibitors and the dipeptidyl peptidase 4 DPP4 inhibitors. Agents in both groups lower blood glucose and are beneficial in the treatment of type 2 diabetes, but only the SGLT2 inhibitors have been shown to have these beneficial cardiovascular and renal outcomes. There are, as you mentioned, valid concerns about the risks associated with the SGLT2 inhibitors, including a black box warning. And there had been one small prior open label study in lupus on these drugs. Can you tell us about that study? Why was it essential to gather more in-depth data for people living with both lupus and type 2 diabetes?
Yeah, so there are risks or potential risks associated with the SGLT2 inhibitors, and these have been seen in patients with diabetes in particular. There is an increased risk of diabetic ketoacidosis, which doesn't particularly apply to lupus patients without diabetes, but definitely those with diabetes. And then infections, presumably because a lot of glucose is going out in the urine. So that would kind of, make a soupy glucose laden broth for urinary infections. So both routine urinary tract infections as well as complicated infections. And then there's one type of really severe perineal genital infection called Fournier's gangrene, which is just a horrible genital gangrene bacterial infection, which has been shown to be increased. And then there was also for a while a black box warning about lower limb amputations in severe diabetics. And so for those reasons, I think there were valid concerns about the risk of infection of these medications in patients who may be already immunosuppressed and at increased risk. And there was one, as you mentioned, small open label trial that I'm aware of that was done in China. And it was published in RMD Open in 2022, I think by Wang et al. And it was a single arm open label trial of 38 patients. 21 of them had lupus without renal disease and 17 had lupus nephritis. And they were given dapagliflozin, 10 milligrams a day for 6 months. And their primary outcome was safety. And the secondary outcome was disease activity. And they did see a high rate of adverse events of all kinds. About 50% of the patients had some kind of adverse event in that small trial. And there were 2 serious adverse events. One was a major lupus flare, as we might anticipate, and one was a pneumonia. And there was one lower urinary tract infection. And they didn't see in this short term, 6 months, I don't know. In the 6-month trial, they didn't see any impact on lupus disease activity or proteinuria in the 17 patients who had renal disease, but they did see a significant improvement in EGFR in those patients. So it was kind of plus minus, and I think left us with a lot of equipoise about these SGLT2 inhibitors or dapagliflozin in this case, working in patients with lupus and lupus nephritis and the risks and benefits.
Okay, so this study, your study, is a population-based target trial emulation. What is this, and who are the patients being studied?
Yeah, so this is a big, as you said, target trial emulation study. And so here we're looking to emulate the clinical trial we would like to run. But it's often really impossible to have a very large trial of patients with lupus who are then randomized to receive either an SGLT2 inhibitor or placebo or versus another medication for lowering blood sugar over a long period of time. So that would be a lot of patients to randomize and follow for a long time. So here we took an administrative database, which has a very large population of people, and we identified people through their insurance claims, and then some of them had linked EHR data. And we set it up as though we were conducting a randomized trial. So we selected patients they all had diabetes, and then they were starting an SGLT2 inhibitor or a DPP4 inhibitor for their diabetes. And then we found that people had lupus. And we ended up doing propensity score matching to end up with 2 populations as though we had randomized people, because we don't randomize people and physicians have their reasons for choosing an SGLT2 inhibitor or a DPP4 inhibitor. We think that hopefully it's kind of a coin flip that which one they might have chosen because we want two similar populations. But we ended up with pretty similar populations of patients who had both lupus and type 2 diabetes. And we then followed them for a variety of outcomes that we were interested in, especially the cardiovascular and renal and safety outcomes through their billing data about a mean of about 8 years here, which is a long time. So there are lots of advantages to doing this in a big study. We use the Trinetics database, which is a very large insurance database, and we could identify a lot of people and very closely match them and follow them for a long time.
So, table one is very revealing because, as you mentioned, this is a huge insurance data set. You had more than 7,000 patients with both lupus and type 2 diabetes who was prescribed one of these two agents. I can't imagine being able to run a clinical trial that big. You also did this propensity score matching analysis to make sure there wasn't confounding in the prescriptions. Talk us through the key points in table one.
Right. So in table one, I think we can compare before propensity score matching on the left to the after the propensity score matching on the right. And as you mentioned, there were 7,000 patients, but a lot of them were getting the DPP-4 inhibitors. So we identified people who had a new prescription. So that's really kind of important in this kind of emulated trial design, that we want new prescribers, and we had a washout. They couldn't have taken another medication for at least 3 months in the past. Maybe we could have made that longer, but so it was a new prescription. So we're starting from scratch. We collected baseline data on them for the past 2 years. So everybody had exactly 2 years of data before the initiation of either SGLT2 inhibitor or the TPP4 inhibitor. You can see the columns of before propensity score matching. They weren't perfectly matched. And you can see that in the SMD, the standardized mean difference between the variables. There was a little bit of difference in the DPP-4 inhibitor prescribed patients were a little older, and there were differences across the board in all the variables we were looking at. Some of them were more different than others. So then we developed a propensity score, which is actually a logistic regression for the propensity to get one medication versus the other. And we gave every patient a score, and we tried to match really as closely as possible on that score. And then people were trimmed at the edges if they didn't match very well on the score. So we ended up with a smaller population of SGLT2 inhibitor patients, about 2,000, and about 2,000 very closely matched DPP-4 inhibitor new prescription patients. And then you can see the SMDs are all very, very small. Basically, less than 0.1 means they're very well matched, and they were all very well matched. And the ages are similar, the sexes are similar, and right down the line of all the clinical variables, they're very similar. So everything that we had access to that we thought might influence a prescriber to give either an SGLT2 inhibitor or a DPP4 inhibitor was very closely matched, so that it was as though we were doing a randomized control trial and a coin flip or a randomized assignment to one or the other. Of course, there are still other things that may have influenced this decision that we didn't have access to, but we used everything in the data set, including labs on a subset of people.
Amazing. So tell us what outcomes you looked at and how did you get data on these outcomes from the insurance-based cohort? Were you relying on coding data, and how did you verify that data?
Yes, definitely. So table 2 has all the outcomes, all our a priori outcomes, what we're really interested in. We were interested in all-cause mortality. That's a signal that we want to investigate, where there are differences in mortality. And then the renal outcomes, acute kidney failure, chronic kidney disease, end-stage renal disease. And then we were interested in lupus nephritis, and we were interested in new incident lupus nephritis, which we discussed quite a lot in this. And since we're interested in the onset of lupus nephritis, so among patients with lupus, we know that actually most patients with lupus nephritis will present with their lupus nephritis, but there is about 30% of patients who will develop lupus nephritis later in their disease course. And we were interested in whether among them, if they had been on an SGLT2 inhibitor versus a DPP4 inhibitor, they would have a lower risk of developing incident disease. So we excluded anyone with lupus nephritis at baseline. So that's one wrinkle here, that we're not studying patients with lupus nephritis and diabetes, but we were looking at that as an incident outcome. And then we also looked at cardiovascular disease outcomes and safety outcomes. And then, as you noted, that we did this using billing codes, and that has pluses and minuses. And when you use coded data, we couldn't hand verify that all the patients had all the conditions that were coded. And some of them are better coded than others. And many past studies have studied this. Mortality is usually pretty well coded. Emergency room visits are captured, hospitalizations are captured, but then sometimes other things are less well coded, and these have been studied. And there are algorithms for identifying some of the infections. We developed an algorithm for looking at lupus nephritis. So they're based on billing codes. And here we didn't use the combination of billing codes and medications, which you could have, but there probably are some problems with that because it can be overly specific and then you can miss people. So you're always trying to have a combination of sensitivity and specificity. And it's not perfect. That is one of the limitations. We have huge amount of power. As you mentioned, we would take a long, long time to randomize this many people or to even find this many people with lupus and diabetes and then randomize them to getting one or the other and follow them for 8 years. But it's not 100%. And we think that most of these are probably well captured, but we don't know for sure. In terms of lupus itself, we've done work in this area, our past work in different cohorts, including Medicaid and our Mass General Brigham cohort, looking at billing codes, and then populations in Canada and Tennessee have done work looking at the billing codes and the validity of capturing lupus. And then so here we also conducted a sensitivity analysis. What we've used many times is 2 billing codes for lupus separated in time. And that's not 100%, but it has pretty good validity, positive predictive value. And then we did a sensitivity analysis using 3 codes, which has increased specificity, but might lose a little sensitivity. And the results were very similar. So that's the kind of thing. Sometimes if you want to make sure you have the right diagnosis codes or you're capturing people, you might do a sensitivity analysis like this.
Oh, thank you for explaining that to us. Can you tell us a bit more about the prescribing of lupus-related medications in these patients? And I guess I really want to know, are they just very, very well-controlled patients with lupus? Because I was surprised to see that less than a third were on hydroxychloroquine. What about steroid use, other immunosuppression in this population?
Yeah, so back to table 1, we do have medications at the bottom there. And I also was surprised at the low prescribing of hydroxychloroquine. As you know, in rheumatology, we think that hydroxychloroquine shouldn't really be in the water for everybody with lupus. And here, only about 29-30% of patients were taking hydroxychloroquine. And I wonder if that relates to the fact that they also had diabetes. Because one reason that prescribers may not use long-term hydroxychloroquine, at least, is because of the retinal toxicity. And we know that that's also a possibility in patients with diabetes. And definitely ophthalmologists and hydroxychloroquine prescribers get nervous about the risk of retinal toxicity and the combination of the two. So I wonder if patients were thus have a lower prescribing rate. But actually in our past work in Medicaid, these are mostly private claims. But in Medicaid, we've also seen kind of horrifyingly low rates of use of hydroxychloroquine, even from the onset. Here, we don't know the duration of lupus either. And we don't know really in terms of their activity. You said, in terms of were they really well controlled? We don't know. It could be that they had a longer duration of lupus and then they had been on hydroxychloroquine in the past, but was stopped because of their diabetes. It's possible. The other thing you mentioned is glucocorticoids. So I was horrified in the other way a little bit by the very high prescribing of glucocorticoids in this population of lupus patients. And they do have diabetes. And so why were 62% of them getting some kind of glucocorticoids? This is glucocorticoid use in the past 2 years. We don't have all the doses. It could be a short taper, it could be a low dose. We don't know. But still in diabetics, we definitely are trying to get away from using glucocorticoids that much at all for many of our rheumatic diseases now. And in diabetics, we have to be even more wary because they push up the blood sugar. We were also thinking, well, maybe some of these patients develop their type 2 diabetes because of their glucocorticoid use. We know in lupus, we do see glucocorticoid-induced diabetes and hyperglycemia, and maybe they had to be put on their SGLT2 inhibitor or their DPP-4 because of their hypoglycemia due to their glucocorticoids. And then there was a smattering of other immunosuppressive use. Unfortunately, it was a little low. Methotrexate was up there. Rituximab was actually very low. And then mycophenolate, as you'd expect in some patients, but really not a lot of other immunosuppressants. So it would be a shame if these patients were being managed mainly by glucocorticoids.
Yeah, definitely. So when you looked at cardiovascular and renal outcomes in the patients receiving SGLT2 inhibitors and DPP4 inhibitors, what did you find?
Yeah, so back at table 2. So I think the first thing was mortality, and we did not see any difference in mortality in our, so it's really the propensity score matched results we're looking at here. The, simulator emulated clinical trial hazard ratio was 0.89, and that was not significant. So that's good in terms of overall safety. And then for the renal outcomes, we were happy to see that the SGLT2 inhibitors compared to DPP4 inhibitors were all very renal protective, as we would expect. So for acute kidney failure, chronic kidney disease, and end-stage renal disease. And again, we don't know whether this was from lupus or from diabetes, probably from the diabetes. And this has been shown in big trials. All these patients had diabetes, but they did have lupus as well. And so we don't want them to get end-stage renal disease or chronic kidney disease from any cause. When we looked just at incident lupus nephritis, unfortunately, we had a small number of events because this was new onset lupus nephritis. And we didn't see any significant decrease in the risk of developing lupus nephritis after starting SGLT2 inhibitor versus DPP4, but the hazard ratio was reduced at 0.67. And, it was suggestive, but because of the small sample size, there was a wide confidence interval. And then cardiovascular outcomes, we didn't see a signal for myocardial infarction or stroke, but for heart failure, there was a 30% reduction with a hazard ratio of 0.72 or 28% reduction. And that was very significant. So that is really good news, I think, for patients with lupus and diabetes here, at least, that their risk of heart failure can be reduced so much. And then we're obviously very interested in other safety outcomes. And interestingly, the risk of having any emergency room visit was decreased. So there was significantly fewer emergency room visits. And then there was actually also decrease in sepsis, which was interesting, about a 40% decrease in severe sepsis, which we weren't anticipating because we were thinking that these medications might be associated with infections, but there was actually a decrease. And the one kind of infection that was increased was the genital infection, which has been reported, and I mentioned earlier, and that was about a 31% increase. So that is there for these patients, as well as, other diabetics and other people. But all kinds of urinary tract infections did not seem increased. And then we looked at other infections. Zoster was not changed. Diabetic ketoacidosis, which has been reported in past trials, was not different in this group. Fracture, because there's been some thought that maybe these medications could contribute to osteoporosis and fractures, but we did not see that. We looked at new use of mycophenolate and of rituximab as surrogates for more severe disease or onset of lupus nephritis, and we didn't see anything there either. So that's kind of the takeaway, that these patients with lupus and diabetes did have similar benefits and not a lot of risk, which is good. The known risk of genital infection was the one risk we did turn up.
Yeah, amazing. So you also did some subgroup analyses. I don't know if there's other things you wanted to walk us through there.
Yeah, well, the main subgroup analysis we did was by race, in that lupus severity often differs by race and is more severe with higher prevalence of lupus nephritis and more severe lupus nephritis and higher incidence of end-stage renal disease. And we wanted to make sure that we didn't see a differential effect in those of different race. And we didn't really. We had smaller numbers of Black patients versus white patients, so we probably had less power, but the benefits did extend to both, with decreased risk of renal disease and decreased risk of heart failure being the main takeaways, and these were in all patients. And then we did, as I mentioned, sensitivity analysis, looking at different use of diagnostic codes, 3 diagnostic codes for lupus, and that was also very similar. And, the population was smaller.
Tell us a little bit about the limitations of this study, because as we mentioned at the beginning, these data sets do have some limitations. Walk us through them.
Well, right. Definitely the study does have a few limitations. So despite being a very large data set and having this nice new user active comparator, propensity score, clinical trial emulation design, so we were interested in incident lupus nephritis. I'm also interested in whether these medications might work in those who have prevalent lupus nephritis, but we excluded them at baseline, so we can't address that. We didn't have enough labs on people. You can see at the bottom of table 1 that we did have labs. So this Trinetics is great because it has some lab data, but it didn't have it on large enough sample sizes. Only about 10 to 12% of patients had these linked lab data, which we did put into the propensity score analyses, but we couldn't look at the effect on EGFR itself or on proteinuria itself. We didn't have a lot of granular detail about the types of heart failure, people's ejection fraction, things like that would have been really exciting. But you lose something when you use a big database and you don't have all those details and you can't get into the medical records. And then also in terms of the generalizability, again, these patients had lupus, but they also had diabetes. So we really need to have a study of just lupus patients without diabetes, I think, to see if they also work. I think they do. These patients had lupus as well, but we haven't proven that the renal protective effects and the heart failure would extend to people who don't have prediabetes or hyperglycemia, which a lot of these people might have had. And then we mentioned, the possibility of misclassification because we're using billing code data. So there's this possibility that some of the outcomes may not have been as hard. I mean, most of these are usually well captured: myocardial infarction, stroke, heart failure, etc. But it is possible that they were miscoded, and we didn't capture everything. That the positive predictive value wasn't extremely high. But some of them, I think, hospitalization, emergency room, death, those are very well captured. So there are limitations, but I think it's exciting, and it does point to use of these medications and their benefits extending to our populations.
Yeah, and I really am grateful for you talking us through this particular study, because I feel like it gives us data that we wouldn't be able to get any other way. So tell us, what does this mean for people living with lupus, and how is this study going to change your own practice?
I think, well, in the general population, and definitely in our cardio rheumatology practice, we have been using these medications now for patients who don't necessarily have diabetes, but have cardiovascular risks or have renal risks for other reasons. And I am starting to think that these medications are really pretty safe. There was a small increased risk, as mentioned, of the genitourinary infections, but those have been well documented and need to be discussed with patients. But there were no differences in other safety outcomes and infections, which is great. And they really did protect against heart failure, progression to renal insufficiency, end-stage renal disease. And that is so important in patients with lupus. And I think we need to think about people who have, lupus is another risk factor for cardiovascular disease and heart failure. It's another risk factor for kidney disease, and a lot of people do get lupus nephritis. I think it's the decrease in heart failure risk is exciting, and we might be able to use these kind of prophylactically when we risk stratify our patients for cardiovascular disease. And we think about statins. Do we also think about SGLT2 inhibitors? And then I think the next study we need to do is really to see if they are useful in patients who have lupus nephritis, who do have a lot of proteinuria, maybe, and declining EGFR on that basis, and see if they will slow the decline of renal function as well. That might be exciting to add in. And then I think even in the European lupus guidelines from 2023, they mention SGLT2 inhibitors in patients for lupus nephritis, which is exciting. And I think people are starting to think about them, at least for stable lupus nephritis, maybe not the very active patients on a lot of immunosuppression, but after the early years of a flare and being on high-dose glucocorticoids and immunosuppression, if there's ongoing decline in renal function and proteinuria, maybe those patients, these would seem very safe. And then we need to test whether they can be used as add-ons really early on at the diagnosis of lupus nephritis.
So wildcard question, as someone who is involved with other lupus trials, does this mean that when we're enrolling patients in true lupus nephritis trials, looking at a new agent for lupus nephritis, we should be stratifying people by use of these other agents that could also affect these long-term outcomes?
Yes, I think that's a good point, that as the people adopt these medications and use these as well, that maybe I'm not really sure nationwide how many providers are now using SGLT2 inhibitors in their lupus nephritis patients. As I mentioned, they not been studied early on. They may be used longer term, but in lupus nephritis and even lupus trials, I think these medications do have a lot of protective benefits, and we should be taking them into account at least as well. Yeah, very good point.
Great. Well, so I want to change direction now and ask you a little bit about the evolution of this manuscript. The first two authors on the manuscript, Kevin Ma and Jin Lo, couldn't make it on the show today. And so we're going to give them a little bit of a shout out in absentia. Tell us about them. How did you come to work together on this manuscript?
So my co-authors and first authors were Kevin Ma. He's an epidemiologist, PhD, and he was a postdoctoral fellow at the Harvard T.H. Chan School of Public Health, and now at Mass General Hospital as well. And Junlo was a medical student, now an internal medicine resident. She's at Case Western Metro Health Center. And they were very interested in real-world studies examining safety and effectiveness of SGLT2 inhibitors, which is, as we mentioned, a very compelling area in internal medicine and then the intersection with other specialties. And they came to me saying, we would be interested in looking at immune-mediated inflammatory diseases. I'm obviously very interested in lupus and lupus nephritis. And then we worked out this collaboration, and it was just great working with them. We thought about different data sets to use and then thought about trinetics, and they were able to get access through the Harvard School of Public Health. And they had done other interesting studies looking at SGLT2 inhibitors in other skin diseases, psoriasis. And so I think that given that lupus patients face these uniquely elevated risks, it really was a nice synergy of, I gave them pointers on lupus and what to consider. And we thought about the study design and how to make this into the most rigorous emulated trial possible. And so it was fun working with them.
So since you bring it up, you decided to use this large insurance data cohort for this study. What factored into that selection? Is this a data set you've used for other studies? How do people access it? And do you have any tips for our listeners on how to access large insurance data sets?
Yeah, another good question. So, we consider various options, including, kind of cross-sectional or single center data sources. We have a large population here at MGB, but not large by any means compared to this data source. So each of these could yield important insights into different aspects of lupus care, and you can really get into the details of the quality of care and lupus disease activity and severity and the laboratories and service delivery. But we chose this very large third-party managed data set because it offers de-identified multi-center electronic health records in some cases with this linkage capability and many different hospital systems across the country and the world, which was really a benefit here because it overcomes the limitation of just having inadequate follow-up treatment data in one single center, and it really generalizes this to across many centers. And thinking about large insurance databases like this, they have strengths and weaknesses, and they're very good for this type of emulated clinical trial and developing real-world data. And even the FDA is getting excited about seeing real-world data on, especially for questions like this involving medications, where you can think of a comparator population with an active comparator and a new user design, and where there might be equipoise in a physician's or prescriber's decision to reach for one medication versus the other that would be kind of equally used or interchangeable. And then you can design a randomized trial like this. And these are really strong data of how people are actually using medications here for diabetes and lupus in the general population across the country. I think the main tip or pointer, which is pretty obvious, is that you really have to know your data set. So after picking which data set you might want to use and then trying to get access to it, which is not always easy, the Trinetics database is not available to all. It can be expensive and you have to get access to it. And then you have to know a lot of the granular things that sometimes it's hard to find out about these different insurance databases, and they don't necessarily want you to know. We didn't have race, ethnicity on everyone, just a subset. We only had lab data on a subset and trying to figure out who we did and who we didn't have and what biases that might introduce. And sometimes people don't realize that even years are missing between when the people might have been collected at baseline and when they're followed up. Or I think the devil can be in the details, obviously, of what is in the data set and what is not.
Yeah, so a lot of quirks.
My pardon?
A lot of quirks.
Yeah, there can be a lot of quirks, exactly. We had to look at the face validity of who was involved, and we thought about questions like you asked about why the proportion of patients getting hydroxychloroquine was low, but the glucocorticoids was high, and or these real lupus patients, and how did they get their diabetes and things like that. So there are definitely strengths and weaknesses, and this kind of real world data is very exciting, but it does have limitations, especially if you don't really know the data well.
Okay, so the tricky question now, as an epidemiologist and a clinical trialist, but also someone who sees patients in practice, what's your take on using an emulation as opposed to a clinical trial? And is this really sufficient to guide decision-making for clinical practice?
I think it really contributes to other data. I think that we will never have a trial, as we mentioned, of 2,000 patients with lupus on SGLT2 inhibitor versus placebo or DPP4 followed for so long. And these are very strong data showing that the benefits, the renal and the cardiovascular benefits extend, and there's no big safety signal. I do think we need smaller clinical trials for more focused questions. And we do need to get into the weeds and get the details, especially for the question that I think is very interesting of, can we use these medications as adjuncts early on when someone is newly diagnosed with lupus nephritis? They have hypertension, they're on high-dose glucocorticoids, they are on immunosuppressants, they have proteinuria, the decline in their eGFR is the most steep. Would these medications help, or would there be increased risk in that setting? And I think we will need smaller clinical trials to address that. As I mentioned, there's only been the one small trial so far of 38 subjects and 17 with lupus nephritis. And it showed there were some adverse events. And so we need to continue. And the two are complementary. The real world data gives us one type of data, but the generalizability here is only that these are patients we don't know how long they've had their lupus or how severe it is. They weren't taking a lot of immunosuppression, and they had diabetes. And then what about patients without diabetes, but with very active lupus nephritis or very active lupus who have cardiovascular risks? I think those are still open questions.
Yeah, so I feel like more to come and really exciting work. I want to thank you, Karen. This was a great discussion. I always learn so much from you, and I'm grateful that you took the time to share this work with our listeners.
Well, thanks so much, Vicki. This has been a great conversation. It's been nice to be with you.
And today, a huge thank you also goes to epidemiologists who help us utilize existing data to inform our approach to addressing unanswered questions in medicine. This manuscript made me realize that the answers are out there. Rheumatologists must keep asking the questions that matter for our patients living with autoimmune diseases. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.